You're listening to Admitting Diagnosis, the Journal Watch podcast for February 13th. I'm Joe Elia. We offer news headlines and an interview. Our interview this week concerns opioids. There are new guidelines and new attempts by the FDA to regulate their use, and perhaps your ability to prescribe them. Now, here are the week's top clinical headlines. First, severe ankle sprain responds best to immobilization in the short term. Next, multivitamin use not associated with lower risk for cancer or CVD in women. And the third and fourth stories are related to the opioid interview. Now for some details. Ankle sprains are a common problem, and the received wisdom, at least the received wisdom lately, is to get the patient back to full activity as soon as possible. Not so fast, say British researchers who randomized 600 patients to treatment with either an air cast brace, a below-knee plaster cast, the Bledsoe boot, or everyone's favorite, the double-layer tubular compression bandage. At 3 months, the patient's assessment of their outcome definitely favored the plaster cast and the air cast. The Bledsoe boot and the compression bandage were both equally ineffective in comparison. However, by the 9-month mark, self-assessments showed no advantage for any of the approaches. Read all about it in Lancet. Next, it's Valentine's Day weekend, and if you've given your sweetheart a bottle of multivitamins, it's not going to protect her against cancer, heart disease, or an early death. That's the word from the Women's Health Initiative, which has a paper in the Archives of Internal Medicine. 160,000 women had a lot of information recorded about their health and habits. After 8 years of follow-up, those who'd taken multivitamins showed the same rates of cancer, cardiovascular disease, and mortality. The multivitamins did, however, confer a lower risk ratio for myocardial infarction, but the authors say this effect may be a statistical artifact. Our interview is next. This week, the FDA served notice that it is going to tighten control on opioid prescribing, telling a news conference that it wants to ensure that the drug's benefits outweigh their risks. The agency announced a meeting with major manufacturers for early next month. The FDA's announcement implied that physicians will have to somehow become certified specifically in opioid use before being allowed to prescribe the drugs. Coincidentally, on the day after the FDA announcement, the American Pain Society and the American Academy of Pain Medicine issued guidelines relating to the use of opioids for the relief of non-cancer pain. The first author listed on the guidelines, which were published in the Journal of Pain, is Dr. Roger Chou. Dr. Chou is an associate professor in the School of Medicine at the University of Oregon. Thanks for taking the time, Dr. Chou.
Thank you.
I know that the FDA's announcement was not related to the guidelines that the societies issued. There seems to be a lot of activity in this area suddenly. Are things getting worse in opioid overuse and abuse?
I think there's an increasing recognition that these medications are potentially dangerous, both to the individuals who are being prescribed them as well as to society as a whole. These drugs get out into society. Kids get into their parents' cabinets. There are overdoses occurring. And, there's a real need to balance potential benefits of opioids, which are that they can relieve pain and help people get back to some semblance of a normal life, while mitigating and minimizing those risks. And I think it's a nationwide effort in the pain community to try to reconcile those things better.
I see. I've talked with physicians who are skeptical that their colleagues, not themselves, but that their colleagues would find the time to take the necessary training if that's what the FDA is going to mandate. Referrals to pain specialists aside, isn't it? There isn't much financial incentive to prescribe an opioid, is there?
No, and it is a tricky question because we do worry about we don't know what the FDA measures are going to look like at this point. You do worry about barriers to prescribing these drugs because there may be some good consequences to that, which is that some people who don't necessarily need the medications or who are too risky for those medications might not get them. but there are also bad unintended consequences that are possible, which is that people who need the medications aren't getting them because their clinicians are afraid to, not because there's a clinical reason for it, or the clinicians can't be bothered. The reality in this country is that 90% of people are prescribed opioids through their primary care provider. They're not going to specialized pain clinics or pain specialists. We don't have enough of them anyways, and a lot of these patients with chronic pain may not have insurance or are underinsured, and it's very difficult to get them in to the pain doctors, even if the pain doctors are available in their community. So there are definite issues that need to be thought out carefully. The FDA announcement does clearly state that they don't want to limit appropriate use of opioids, and I think that everyone needs to keep that in mind as this process moves forward. It's still very early, so we don't know exactly what everything is going to entail yet.
Yeah, it does seem from the announcement from the press conference that they held that there will be some kind of a restriction or some kind of training mandated for physicians who are going to prescribe opioids. And so I guess we'll just have to wait until March or until they make their decision about it. Speaking about your recommendations and your guidelines now, I should say that they're available free in the Journal of Pain, and they're very extensive. There are some 25 recommendations. But as I was reading through them, I noticed that the evidence base, and you and your co-authors say this as well, the evidence base for the recommendations is pretty sparse. Do we not know enough about these drugs yet?
Yeah, I think that would be fair to say. We need to know a lot more, certainly. These drugs aren't simple drugs like like using atenolol, say, for blood pressure, where you don't need to monitor somebody's addiction risk with atenolol. You don't need to kind of do a bunch of pre-assessment stuff. And you don't need to worry about people abusing atenolol or their kids getting it. So opioids are very different in some respects. But the way that research has been done in this country and in the world, for that matter, is that if you can get a approval or indication and you get market share, there isn't much incentive to do more research. So most of the research has really focused on short-term use of these medications, and we know that many patients get these drugs for a very long time. It's also focused on low-risk populations, so people that don't have risk factors for abuse and addiction. But we know that a lot of people, have those kinds of risk factors and are getting these drugs. So there's a lot of stuff we need to know in terms of monitoring, how to monitor and select patients, how to mitigate the risks, how to choose people most effectively for these therapies. The panel, you have to make clinical decisions based on what's out there now. Otherwise, clinicians, it's not useful to clinicians to not have practical advice about what to do. So the panel, the goal really was to review all the evidence. When there was good evidence, to make recommendations based on those. When there wasn't, the panel, is forced to rely on lesser evidence and in some cases to rely on expert opinion and kind of anecdotal evidence. The reason that the recommendations are graded the way they are, they're graded as being strong or weak recommendations, and then the evidence is also graded as high, moderate, or low quality evidence, is to let readers know that things could change. If something is graded as being low quality evidence, that means that if research comes out showing that something different, that recommendation is likely to change. Right. Something that's graded as being supported by high-quality evidence, unfortunately we don't have any instances here. We do have some instances of moderate-quality evidence. There's more certainty about that, and those would be less likely to change with more research. One of the things we hope with this effort is that identifying these research gaps systematically will help inform funding and research priorities from the government and other funders. And in fact, one of the papers that accompanies the guideline just deals with research gaps. Mm-hmm.
You say in one of the recommendations that you make is that patients on chronic therapy should be able to identify a physician who accepts primary responsibility for their overall medical care. Would you consider that the most important of the guidelines?
I think that's a very important one. I mean, I think there's several important recommendations.
I was going to ask you what you consider to be the most important recommendation.
I mean, that's a tough question. I mean, I think having somebody that takes primary responsibility, that is important because many patients kind of get lost, and if somebody is getting their opioid medication from a pain specialist who isn't necessarily involved in the rest of the patient's care, that can be an issue. We have a lot of studies showing that patients with a primary care physician do better, even after adjusting for all of the factors that can affect longevity and health. Having a primary care doc really makes a difference. And I think a lot of people are recognizing this. There is this medical home movement in the United States. This is really a way of coordinating health care and keeping the patient at the center of things. So I do think that's an important recommendation, and it's a remarkable one coming from this panel because, we did have primary care representation on this panel, but a lot of the members on this panel were pain specialists. And for everyone to agree on that, I think, is a remarkable thing. The key, finding from this from the guideline is that these medications can be used effectively, and they can be used with reasonable safety. But you really need to select patients carefully. The patients need to be counseled about the medications, and they really need to be monitored regularly and thoroughly for side effects and possible abuse or aberrant drug behavior. So there's 6 or 7 recommendations that kind of deal with those issues, and I think that I think would be the key message here.
Okay.
Clinicians, the purpose of the guideline is to help clinicians understand how to do those things. Like we were talking about the FDA earlier, wanting to certify physicians or clinicians. And really the guideline is trying to provide the types of information that clinicians need to know to be able to prescribe these drugs safely.
And I guess then that it's not the pharmacology of the drugs that's so important. It's how we sort of try to integrate them into society. And as you've said a couple of times, these drugs find their ways into places where they shouldn't be, like they're in parents' medicine cabinets, so the kids get at them, or people overprescribe them abusively, or people take them abusively, and I guess it's the monitoring of those things that's more important than. I guess we know enough about the drugs to know that they relieve pain, but as you say, using them properly in the right patients is key.
Yes, exactly, and there's a lot of kind of issues here. I think that it can be easier for people to put somebody on these medications and just kind of keep cranking up the dose without really carefully assessing to see if somebody is benefiting, whether other stuff is going on that might signal that the drug is being abused or diverted for other purposes or being sold or whatever. And it's really important for clinicians to continually reassess the situation. They need to look at the patient as a whole, see if they're benefiting, what kind of harms they might be experiencing from the drugs. If there are alternative therapies that might be safer and more effective, those need to be considered as well. Opioids shouldn't be taken lightly, but we also don't feel that clinicians should be afraid of prescribing them once they, if they understand how to assess patient risks, monitor those risks, and develop a plan to manage, whatever risks might be there.
Well, that's great advice, Dr. Chou. I want to thank you for spending time with us today.
Thank you.
Finally, this past week saw the observance of Charles Darwin's 200th birthday. A poll of some 1,000 Americans found that fewer than half believe in the theory of evolution. So my question as an American is this: why do you believe anything I tell you? Happy birthday, Chuck. As for the rest of you, have a great week of healing. And if you want to comment, complain, or cajole, call 617-440-4374. If you'd like links for any of the stories or access to any of our interviews, go to podcasts.jwatch.org. Our executive producer is Adore Yano, and I'm Joe Elia, in charge of birthdays. We'll see you next week. Thanks for listening to Admitting Diagnosis.